The McEwan triangle, also called suprameatal triangle or mustard fossa, is a surgical landmark on the surface of temporal bone, just superior to the external auditory canal. This is used for location of the mastoidectomy. There are three boundaries of this triangle. Superiorly, inferior temporal line or supramastoid crest extending back from the posterior root of the zygomatic process to the isthmus temporal bone. Anteroinferiorly, tangent extending from the posterior superior border of the external auditory meatus, including the suprameatal spine of the Henle, and posteriorly, vertical tangent extending up to the posterior border of the external auditory canal. So these three lines define the McEwan's triangle. The spine of Henle or suprameatal spine or spina suprameatica is a guide to the lateral wall of the mastoidectomy. It is located posteriorly on the lateral aspect of the external auditory canal. So this spine guides the mastoidectomy. The triangle of attack is the starting point of the cortical mastoidectomy. There are three lines. First line is the suprameatal line, that is upper limit of the external auditory canal extending from zygomatic bone to the sigmoid sinus. Second line, which drill parallel to the posterior to the external auditory canal. And third line connect the first two lines, and you can start drill between these three lines. So this is called triangle of attack. The cibriform area in the McEwan's triangle is perforated by numerous small holes that serve as passage for the vessel for the mucosa of the antrum. You can see there are multiple holes in the cibriform area just behind the spine of Henle. That also suggests the position of the antrum. Facial bridge is the portion of posterior superior bony meatal wall that bridges over the notch of Venus and overlies the ossicle, and this covers the part of the facial nerve from first genu to the second genu. So this is the part of the posterior meatal wall which cover the notch of Venus and tympanic portion of the facial canal. The notch of Venus is a small defect in the posterior edge of bony annular tympanic ring. The defect is located just superior to the tympanomastoid suture line in the posterior ear meatal canal. This bone, where this notch of Venus is present, above this bone is called the facial bridge. Buttress. Buttress means support. Anterior buttress is the point at which the posterior bony canal wall meet the tegment. Is called the anterior buttress. Posterior buttress is the point of which posterior canal wall meet with the floor of the external auditory canal just lateral to the facial canal. So posterior buttress is the support between the posterior canal wall and the facial nerve with the floor of the external auditory canal. After removing the facial bridge, the remaining part you can see that is the anterior buttress, and remaining posterior part which is near to the facial nerve is the posterior buttress. Facial ridge is the part of the bony meatal wall which houses the posterior band, means second genu, and vertical segment of the facial nerve. So bony portion that cover the facial nerve from the second genu to the stylomastoid foramen is called the facial ridge. Sinudural angle or stellage angle is angle between the sigmoid sinus and middle fossa dural plate. Actually this angle is between the sigmoid sinus and superior petrosal sinus. So actual angle is between the superior petrosal sinus and sigmoid sinus. It is the meeting point. That angle considered as a stellage angle or sinudural angle. Significance of this triangle, it defines the boundary of the vascular elements like superiorly superior pituitary sinus and inferiorly sigmoid sinus. These are the vascular elements. So this prevents the injury of these two elements. Trotman's triangle is bounded superiorly by superior pituitary sinus, posteriorly by sigmoid sinus, and anteriorly by the bony labyrinthine. It serves as surgical pathway to the posterior fossa from the mastoid cavity. Significance of this triangle is one is any infection in mastoid cavity can spread to the posterior cranial fossa through this route. Another, you can approach the posterior fossa lesion through this transmastoid approach or trans-Trotman triangle approach of the posterior cranial fossa lesions. Anterior boundary of this is the solid angle. What is solid angle? Solid angle is the meeting point of all three semicircular canal of the bony labyrinthine. That is called solid angle. Parietal notch or Bremer's pointer is a reliable surgical landmark to identify the position of sigmoid sinus at the sinodural angle. Parietal notch is a surface landmark on the posterior superior aspect of the mastoid process of the temporal bone and is defined as the point where the squamous suture lines meet with the parietal suture line. It is located anterior to the asterion, the point on the lateral skull base where the lamboid, occipitomastoid and parietomastoid sutures meet. The asterion is sometimes used by neurosurgeon during retrosigmoid craniotomy to help identify upper hole site posterior to the sigmoid sinus and inferior to the lateral sinus. In about 45% of cases, there is distinct cell type present that is called Herald cell. This cell is the gateway to the posterior tympanotomy. Posterior tympanotomy is the avenue of facial recess of the middle ear from mastoid antrum. The entry into the facial recesses many times is heralded by the distinct ear cell before approaching the facial caudal plane. This cell is known as Herald cell. Posterior tympanotomy or facial recess or Bulstein window is bounded by the facial nerve posteromedially, cauda tympani anterolaterally, and incus buttress or fossa incudis superiorly. You can see in this picture. This posterior tympanotomy mainly carried out in intact canal wall cholesteatoma surgery, cochlear implantation, and active middle ear device implantation. The facial recess is defined by the line drawn through the body of the incus across the posterior bony canal wall and posteriorly the facial canal wall, anteriorly being the caudal canal wall or cauda tympani. The landmark may be horizontal semicircular canal, short process of incus, tympanic segment of facial nerve, mastoid segment of facial nerve, cauda tympani, incus buttress, posterior tympanotomy ear cell tract that is Herald cells and caudal crest. These are the landmark to assess the facial recess. Digastric ridge is a bony elevation present inferiorly in the mastoid cavity at the level of mastoid process. The digastric ridge corresponds externally to the digastric groove at the medial aspect of the mastoid process, from which the posterior belly of digastric muscle originates. The digastric ridge divides the mastoid tip cells into two groups, lateral and medial group. Clinically, the digastric ridge is an important landmark in identification of the facial nerve and sigmoid sinus. The morphology of digastric ridge varies from person to person and usually more prominent in pneumatized mastoid than the sclerosed mastoid. This digastric ridge extends from sigmoid sinus posteriorly to the posterior meatal wall anteriorly. Average length of this digastric ridge is about 1.7 centimeter. The entry end of the digastric ridge is one of the landmarks to identify the vertical part of the facial nerve. The mastoid segment of facial nerve lies anteromedial to the anterior end of the digastric ridge at varying depth. Depth about 4.5 mm in the pneumatized mastoid and 3 mm in the sclerosed mastoid. So importance of digestive ridge. First is digestive ridge is important landmark to identify the vertical segment of facial nerve during mastoid surgery or transmastoid approaches to the middle or posterior cranial fossa. Second, facial nerve always lies medial to the anterior end of the digestive ridge, and length of the digestive ridge and distance of facial nerve from anterior end of digestive ridge are more than more in the pneumatized mastoid than the sclerosed mastoid, and it's also provide safer surgical corridor to prevent injury of the facial nerve or sigmoid sinus. The mastoid process is a smooth conical projection of bone located at the base of the mastoid area of the temporal bone. It allows the attachment of muscles such as occipitofrontalis muscle as well as certain muscle of the neck like sternocleidomastoid muscle, splenius capitis muscle, longissimus capitis muscle, and the digastric muscle. Inferior surface of the mastoid process having digastric fossa or mastoid notch, a groove located on medial side of the mastoid process, which is corresponding to the digastric ridge in the mastoid tip during mastoidectomy. This notch having insertion of the posterior valley of the digastric, which is most medial muscle of the mastoid tip. Another groove is the occipital groove, a furrow located medial to the digastric fossa or mastoid notch, that having the occipital artery that is arises from the external carotid system and mastoid ear cells. These ear cells are superior, inferior, and anterior area of the mastoid process. They are larger and more irregular cells. So these cells are located in the mastoid process itself. The rough outer surface of mastoid process also allows the attachment of occipitofrontalis muscle, and this muscle wraps the skull from superior nuchal line to the mastoid process. So most superficial and lateral surface muscle of the mastoid process is the occipitofrontalis muscle, or you can say occipital part of the occipitofrontalis muscle. At inferior surface, the mastoid process having attachment from lateral to medial. First muscle to insert on mastoid tip is sternocleidomastoid muscle. Then posteromedial to sternocleidomastoid is the splenius capitis muscle. Then posteromedial to this muscle is the longissimus capitis muscle, and most medial muscle in the mastoid tip is the digastric muscle, means posterior valley of digastric muscles. The mastoid ear cells present in the mastoid process also serve their own function like protection of temporal bone and middle ear inner ear, protection from the trauma, and regulation of air pressure. They communicate with the middle ear through the mastoid antrum and the editus and the antrum. So this mastoid process is very important for the middle ear function. Today's topic about tympanic membrane. Tympanic membrane is a semi-transparent. You can see this picture. It is not completely transparent. It is semi-transparent partition between the external auditory meatus and tympanic cavity, or you can say middle ear. It is an oval shape, about 10 mm tall, 9 mm wide, and 0.1 mm thick. So thickness is very less, 0.1 mm. It is placed at angulation of about 45 degree to the floor of external auditory canal. It consists of three layers: outer cuticle layer, that is stratified squamous epithelium developed from ectoderm; middle fibrous layer developed from mesoderm; and inner mucosal layer that is developed from the endoderm. And inner mucosal layer is low columnar epithelial layer. The color of normal tympanic membrane is pearly gray or pearly white in color. So there are two parts of normal tympanic membrane, is pars tensa and pars flaccida. Pars tensa is larger part and its periphery thickened and form a cartilaginous ring. That cartilaginous ring is called annular tympanicum. That fits in the bony sulcus, that is called tympanic sulcus, which is formed by the tympanic bone mainly, and that is bony, and it's above deficient, and deficient part of this bony sulcus is called notch of Rabinus, which having the another part of tympanic membrane, that is pars flaccida. And this pars flaccida between the anterior and posterior malleolar ligament is also called Sharpnell's membrane, that is Sharpnell membrane, and it is small triangular in shape. This part, pars flaccida, is triangular shape and it is between the anterior and posterior malleolar fold. It is thin because it doesn't have any fibrous layer. So this part deficient of the fibrous layer of the tympanic membrane. The fibrous layer of pars tensa having three type of fibers. The most lateral fiber toward the external auditory canal are radial fibers, which radiate from the umbo toward the periphery. So in this fibrous layer, most lateral fibers are radial fibers. Another fiber just inside to the radial fibers is circular fiber of fibrous layer. In between intermingled fibers are parabolic fibers. So these fiber are made up of collagen bundles. So outermost fiber in fibrous layer is radial fiber, then circular fiber, then in between intermingled fiber are parabolic fibers. So there are three types of fiber in middle layer, fibrous layer of tympanic membrane. You can see in this picture the layer of outer layer, that is cuticular layer, then followed by fibrous layer, and inner mucosal layer is low columnar epithelium in the section or histology of this tympanic membrane. So tympanic membrane having two surfaces, lateral surface and medial surface. As you can see in this picture, the lateral surface is concave towards external auditory meatus. It divided into four quadrants by the two imaginary lines. First imaginary line passing through handle of malleus and another line passing through the tip of the handle of malleus, or you can say umbo, at the right angle to the perpendicular line of handle of malleus. So there are four quadrants. Anterior inferior quadrant, you can see cone of light is there. Antero superior quadrant, posterior superior quadrant, and posterior inferior quadrant. So cholesteatoma is most commonly occurred because of retraction in the posterior superior quadrant. The medial surface of tympanic membrane is convex and maximum point of convexity is called umbo. Umbo is the attachment of handle of malleus on the tip of tympanic membrane where maximum convexity is toward the middle ear cavity. You can say tympanic membrane. The coda tympani, you can see in this picture, is closely related to upper part of tympanic membrane, that is pars flaccida. Nerve runs from posterior to anterior aspect, medial to the neck of the malleus, close to the tympanic membrane. The relationship of tympanic membrane. Laterally, it is external auditory canal. Medially, there is tympanic cavity. Superiorly, you can see there is middle cranial fossa. Inferiorly, being jugular valve. And anteriorly, you can see there will be TM joint, and posteriorly there are mastoid cavity. So these are the relationship of the tympanic membrane. The nerve supply of tympanic membrane. Lateral surface supplied by two nerves. Anterior part is supplied by the auriculotemporal nerve, and posterior half of lateral surface supplied by vagus nerve, that is Arnold's nerve, and medial complete surface of medial is supplied by the Jacobson's nerve, that is a branch of the glossopharyngeal nerve. Now, blood supply of tympanic membrane. There are three artery supply. You can see first is anterior tympanic artery going through petrotympanic fissure and deep auricular artery going through scomotympanic fissure into the middle ear cavity and supplying the tympanic membrane. They are both artery. This anterior tympanic and deep auricular are branch of first segment of internal maxillary artery. Another artery which is supplying below is the stylomastoid artery is branch of the posterior auricular artery. So overall tympanic membrane supply by the mainly external carotid system and venous drainage mainly in the external jugular vein laterally and medially there is auditory plexus which is going into sigmoid sinus and transverse sinus. Today's topic about middle ear anatomy. It is better is middle ear cleft, having editus, antrum, attic, eustachian tube, tympanic cavity, and mastoid ear cells. You can say the middle ear or tympanic cavity is six-sided box, and highest dimension is epitympanum about 6 mm. So this is middle ear cleft picture you can see. And middle ear is six-sided box. Roof of middle ear is mainly formed by the tegmen tympani extending from tensor tympanic canal up to the editus. So whole length of roof is covered by the tegmen tympani of the tympanic cavity. Floor is thin layer and mainly formed by the jugular wall and sometime may be deficient, and where it is small canal is there that is called tympanic canaliculus which Jacobson's nerve passes through between the internal jugular valve and the ICA, and laterally is covered by the almostly by tympanic membrane and bony outer attic wall that is called scotum, and erosion of this is sign of cholesteatoma. And posterior wall separate middle ear from the mastoid ear cell, editus and fossa incudis, pyramid, vertical facial canal, posterior canaliculus, which the chorda tympanis passes through, is part of posterior canal. Anteriorly, you can see eustachian tube and tensor tympanic canal. And medially is cochlea, anterior oval window. There is hook-like bony projection called processus cochleariformis, tensor tympani tendon, which turns around medially, and it is also mark of the facial canal. Hi guys, this is endoscopic anatomy of the ear. Binocular vision best in microscope, both ends are free. Endoscopic having wide and panoramic view is better visualization. As you can see, the endoscopically middle ear divided into five parts: epitympanum, protympanum, mesotympanum, retrotympanum, and hypotympanum. These five areas are very important for know each and every structure of the middle ear. Now talk about retrotympanic area. As you know, retrotympanic areas are having many bony crest and sinuses. First bony crest you can see is ponticulus. Its connection between the promontory and pyramidal eminence classified as bridge ridge or incomplete. And there is another crest that is subiculum. Its bony structure arising from posterior pillar of the round window next toward the styloid eminence. You can see it is just like bridge ridge or incomplete like ponticulus. Funiculus is conjunction of anterior pillar of the round window niche that up to the jugular bulb, classified again as bridge ridge and incomplete. So there is retrotympanic sinus like posterior sinus is triangular area which is limited laterally, posteriorly and superiorly by facial nerve, inferiorly by ponticulus and anteriorly by the stapes footplate and oval window. Sinus tympani round shaped sinus between the ponticulus and subiculum. And sinus subtympanicus is area between the subiculum and funiculus connected with the round window niche anteriorly. So these sinuses, posterior sinus, sinus tympani, and sinus subtympanicus are, you can see in this picture, are important for hidden areas in the cholesteatoma surgery. Like ponticulus variation, it may be barrier, communication, and true bridge. Barrier means completely there is no gap between sinus tympani and posterior sinus. It allowed direct in beta bit allow direct communication between sinus tympani and posterior sinus, and true bridge is there. You can pass between the sinus tympani and posterior sinus. Subiculum is also having same variations, like it may be variate communication bridge between the sinus tympani and sinus subtympanicus. So these variations are important to know in the middle ears surgery. And sinus tympani may be having three types. It may be shallow, it may be deep, which going to the facial nerve. It may be extend beyond the facial nerve postomedially. So three types of sinus tympani can be seen in the middle ear. So these crest and sinuses are mainly situated in the retro and hypotympanic areas. Now talk about epitympanum. Epitympanum divides anteriorly by epitympanum and posterior epitympanum by cog. Cog divide anterior and posterior epitympanum. What is cog? Cog is transversely located crest which from the tegment to the malleus or behind the cochleariformis process. It is also called transverse ridge crest, and it is located behind the cochleariformis process, which is the fulcrum for the tensor tympani. Process space between the lateral process of malleus inferiorly, pars flacida laterally, and neck of malleus medially. And laterally you can see malleolar ligament superiorly also. So these process space are more prone for cholesteatoma, cholesteatoma disease. You can see this process space in the picture. And you can see antitympanic space for the ventilation of the middle ear. There is two isthmus, antiisthmus and postisthmus, which ventilate the epitympanic area, which ventilate the mustard cell through the epitympanic area. You can see this is a middle ear pressure homeostasis or gas exchange. Now talk about protympanum. Protympanum is anterior to the annulus, having canal for tensor tympani, supratubular recess, and eustachian tube. Superiorly, it is having tensor fold. Medially, lateral part of carotid canal, and inferiorly is a protympanniculus. Proteniculum. Proteniculum is the ridge between the hypotympanum and the protympanum. It may be have ridge, bridge, and absent. Hypotympanum is inferior to the annulus up to the jugular bulb. Depth about 5 to 10 mm. Now talk about mesotympanum. Mesotympanum is the middle area which can be easily accessible by microscope or endoscope. You can see each every like mainly handle of malleus and incus. What is McEwan's triangle? It is having superior supramuscular crest, anteriorly posterior margin of bony external auditory canal, and if you pass a tangent line from the external auditory canal posteriorly, you can see McEwan's triangle for the mustard antrum. You can open the mustard antrum without seeing major structure through this approach. That is McEwan's triangle. So these triangle are very important and basic to know. What is Trotman's triangle? Trotman's triangles having superior petrosal sinus, posteriorly sigmoid sinus, and anteriorly there is a bony angle of all semicircular canals. So these triangle are basic to know for operation in the transmustard approach or middle ear surgery. So this is all about basic of endoscopic anatomy of the middle ear. Thank you so much. In endoscopic middle ear anatomy, there is four bars. First is ponticulus, second is subiculum, third one is funiculus, fourth one is proteiniculum. Area between 1 and 2 is called sinus tympani. Between 2 and 3 is called sinus subtympanicum, and between 3 and 4 is called hypotympanic space. So these area are important landmark in some middle ear surgery as well as inner ear surgery. The sinus tympani is the area between the ponticulus and subiculum. You can see in this picture. The is a medial extension of styloid complex toward the promontory, and this is a bar dividing the round window in almost two halves. Upper half of is from styloid complex to round window is called area concomarata medialis, and below the is which area going toward the subcochlear tunnel is called area concomarata lateralis. So these areas are important for cochlear implantation and singular neurectomy. So this area concomarata is important. Another spaces of middle ear space are posterior sinus, caudal space, lateral tympanic sinus, and sinus tympani. So the lateral spaces are facial sinus, or you can say facial recess, or you can say caudal space are same thing. Below the caudal ridge is a space that is called lateral tympanic sinus, and area around the stapes foot plate is called posterior sinus. It is between the facial nerve and the stapes, and area between the ponticulus and subiculum is sinus tympani.